part one of our second interview, Dr. John Petrozza chats with Dr. Jacques Donnez. Sit back, grab a cup of coffee, and enjoy what we think are valuable lessons about our history, sparking innovation and newer surgical applications of reproductive surgery.
My name is John Petrozza. I am currently the Chief of the Division of Reproductive Medicine and IVF at Massachusetts General Hospital and Harvard Medical School. And I'm excited today and have the great honor of presenting and chatting with Dr. Jacques Donnez. Donnez is one of those rare clinicians in my mind who's really carved out a niche in the field of reproductive medicine, because not only is he an astute researcher, he's also an incredible surgeon. Currently, he is Professor Emeritus at the Catholic University of Louvain, Brussels, Belgium. Hopefully I said that correct, Jacques.
Yes.
He's head of the Department of Gynaecology, and he's been head of gynecology since the mid-1980s, 1986. When I believe you've been chair of that department since 1992. You're the founder of the Infertility Research Institute at the university, and your research interests have focused on tubal fertility, endometriosis, and ovarian transplantation. And you have an astounding 600 plus peer-reviewed journals that you've contributed to, which is phenomenal. There are very few people who have that many manuscripts that have been published. So that's an astounding feat, and we're very honored to have you here. So we're going to start off with some fun stuff first, Dr. Donnez. We're going to start off by looking at some memories, some photos that you shared with us, and hopefully you'll be able to walk us through what those photos are, who's in the photos, and perhaps the scenes, the scenarios, the events where these photos were taken. So I'm going to share this screen.
We will share the slide now, the picture.
I will share the slide. Here we go. Who is this young, handsome gentleman on the screen?
Thanks first for your introduction, very kind introduction. And I send you this slide because, in fact, I was a resident in gynecology. At that time, it was a little bit more relaxed than now. You know, I was on call at the obstetric department, ready to make some delivery. And at that time, the residency take 4 years. And after that, I was sent as gynecologist to Germany. It explained why I'm in the army. I was in the medical group and I was sent to Germany. And at that time, I was not very happy because I was 30, I was married, 2 children, and I was sent to Germany. I was a little bit disappointed. But finally, I met a lot of people there also from the US Army, because the US Army was also in Germany, in Wiesbaden, and at the hospital of Wiesbaden. We were at the hospital of Cologne, and for 2 years, I made a lot of delivery. Finally, I was as a gynecologist in the army, and it was a very good period because a lot of friends were there too, and I spent 2 years coming back to the university.
That's incredible. That's wonderful. So it looks like on this one picture, you're in your scrubs, you have your jacket on. Is that a post-busy day bottle of beer, or is that just some soda? What do you have there?
I have to confess that I asked my secretary to try to remove this bottle. But at that time, you know, that was a bottle of beer, I agree. And during the night, we had not the permission to go to the restaurant. When we were on call, we were obliged to stay day and night for 48 hours in the same office, and that was my office. And we had the dinner, the lunch, and the breakfast we had in the room. And that is a picture taken in the evening, and probably at that time, a drunken beer before going to sleep.
Now, the one other thing I see in this photo are some test tubes with something inside the test tubes. Do you recall what that was?
Systematically, you know, it's a test tube. And at that time, it's in 1972, 73. In fact, after each delivery, we took some blood from the umbilical cord, and these tubes were there in the office, and they will be sent the following morning to the lab. Yes, it's completely different from now. You cannot imagine. That was the reason why I sent you this picture, because when we imagine from 1972 to 2020, the evolution in all this department of obstetric completely different. But at that time, that was like that, very relaxed.
That's incredible. Well, I'm going to move on to the next slide. And can you tell me what's going on here?
Excellent souvenir. That was the World Congress on Endometriosis. You have a Professor the Queen, Fabiola was invited, surrounding the Queen, Professor Brosens there, and myself. And then here, Professor Brua, Michel Canis, Visibutram, John Rock, Dan Martin, Vernon, Schenken, and I don't know if you can see, that was also Mogisi on the slide.
Yes.
And at that time, we had already at this World Congress organized in Brussels, more than 1,600 participants. Why so many participants already? Because that was the year of the launching of the GnRH antagonist, the Zoladex and Decapeptile, and that was a promotion also, and we have a lot of participants. But this photo, it's a fantastic souvenir because that was the first time finally that the expert in endometriosis were invited in a World Congress on endometriosis. And I don't know if you may recognize Michel Canis here, very young, and Maurice Brua.
Yes.
So that at that picture, we had a fantastic congress, and it was for me, I was quite young, and I was president with Ivo Brosens of this World Congress. And that was the start of really an exchange between the US gynecologist and the European gynecologist on this specific disease called endometriosis. I guess that was really the start of a really exciting collaboration.
That's wonderful. And how were you able to get the Queen to be there?
The Queen was invited, and she spent some time at the meeting, in fact, and she was very interested when we discussed the pain, the pelvic pain due to the endometriosis, even in young women. She was really interested, and we had a lot of support thereafter to promote the research, at least in our country.
That's incredible. I mean, I look at this photo and I see some of, along with you, some of the greats in reproductive surgery. It's an incredible group. I can only imagine with so many people there that this must have been a meeting of the minds. A lot of good ideas were probably generated at this meeting.
You told me that you had some difficulty to recognize John Rock.
No, I can see Dan Martin hiding in the back. And, if you hadn't mentioned his name, I probably would not have recognized him, how young he looked back then.
Yeah, very young, huh?
Very young, very young. Well, let's move on to the next slide.
Yes.
What's going on here?
2001, you may recognize here Professor Barlow and here Professor Shaw, president of the Royal College. I was invited as a fellow, I was nominated as a fellow at UNDEM at the Royal College of Obstetric and Gynecology. And for the European people, really to be nominated fellow at UNDEM at the Royal College represent a fantastic honor. And that was made also, that was specific for me, that was a very exciting adventure because Professor Barlow and Professor Shaw involved at that time in the GnRH agonist research in endometriosis. We were involved in the research, in the clinical trial, and that was really, for me, an excellent souvenir to be there with them.
That's a wonderful photo. Was your family there with you on that day?
Yes, the family was invited. My wife was there, and it was a very big ceremony. You may imagine at the Royal College, the British people are still very much involved in the nice ceremony with a lot of very formal, and it's fantastic. And it remains like that now. In 2020, I know that it's still organized like in the past with a lot of very nice ceremonial.
That's wonderful. And congratulations. That's an incredible honor. That was 20 years ago. It probably seems like yesterday to you.
Yeah, more than 20 years ago, yes.
That's incredible. So this is a great picture. I mean, I'm assuming this is one of your patients?
Yeah, this here That was during the pregnancy. I follow Warda. And here, that is the first picture. The day of the birth of the first pregnancy. Here it's Tamara. We are allowed to show the picture of Tamara, no problem. And then Tamara was born in 2004 after transplantation of frozen ovarian transplant. In fact, Warda here, we have still a lot of very good contact with this family and my department. She had a Hodgkin disease, and we start, in fact, the cryopreservation program. We start not the transplantation, the cryopreservation program was started in 1996. And I have a nice story to tell because Bob Edwards, at that time, in 1996, came to Brussels in the symposium. And at that time, Gosden, who is now in the United States, was working in Edinburgh in the department of David Bird, and have made cryopreservation of ovarian tissue in the sheep. And they made the first transplantation in the sheep with successful recovery of the ovarian function. And that was discussed in Brussels in 1996. And Bob Edwards told me, Jacques, why you don't start with a program like that in your university? And Bob told me, you have a big unit of research, you have enough money to start, please start. And we start in 1996. Here, that is the first a picture of Warda and his husband. And Warda, and I know that I may call the story, Warda had a Hodgkin disease, stage 3, but she was pregnant at that time.
Gotcha.
That very difficult decision because we should start the chemotherapy, but of course, that was the pregnancy, we have to stop the pregnancy before starting the chemotherapy. At that time, that was no other way. But before starting chemotherapy, we took a larger piece of one ovary, and in 2003, we reimplant the tissue in the pelvis. And 11 months later, she was pregnant. That was the big surprise. She came back at the consultation and she told us, yes, I had my menstruation sometime, but no anymore. And we did a test. Immediately, we go to the ultrasound equipment, and there was a very small embryo, and she was pregnant, and she delivered in 2004. That was the big story. And at that time, there's a lesson for all the gynecologists. Bob Edwards sent me a letter, and he wrote me, Jacques, now, first, congratulations, but from now, you will know who is your enemy. And you will have a lot of enemies, because when I start with in vitro fertilization, I had a lot of jealousy, people try to kill me, and you will have the same.
Wow.
In fact, when you have a first world experience, many people are jealous and try to destroy you. And that is the most difficult, because it's a balance between the honor, the publication in the Lancet, everybody was happy, CNN was in the department, a lot of things. And on the other hand, the jealous people try to kill you. Are you sure that it's really from the ovarian transplantation that the baby is born? You know, that's always like that. And finally, the first proof that the ovarian transplantation is really a fact was from another pregnancy in a woman who had a bilateral annexectomy. There's no possibility that somebody from the remnant ovary is active. Bilateral oophorectomy, we reimplant the tissue, it works, we make IVF after ovarian stimulation, and she had a baby. That was the first proof that, in fact, really, after cryopreservation of ovarian tissue, reimplantation allow not only the recovery of the ovarian function, but also recovery of the fertility. And that is my best adventure.
That's incredible. Great story. Great story. Did you get a lot of bad letters and feedback during that time, Jacques? Did you get a lot of people who are angry at you? Did Dr. Edwards' words, did they hold true?
Yes. In fact, at that time, we had more or less, now we are we are doing a paper now with the 5 other centers. There are more than 200 live birds in the world from the ovarian tissue cryopreservation. And now everybody is convinced. But imagine that between 2004 to 2007-8, I had to wait. I had a lot of criticism because systematically, when I present the data, somebody among the participants asked me the question, always the same question. Dr. Donnez, how can you prove that the baby is really born from the transplant and not from an ovulation from the so-called destroyed ovary? That was always the same question. But finally, from the other department in Europe, from Denmark, from the group of Andersen, another group, a lot of transplantation were made. And finally, everybody was convinced of the efficacy. But that was really, really difficult because of the jealousy of the people at the beginning.
Yeah, I believe it. Let's go on to this next photo. This is you in the operating room.
On the left, on the left, it's me.
This is you right here on the left.
Yeah.
How long ago is this?
Ooh, I will guess that is the OR1. It's surely, I will say,
probably 2000,
more or less, near between 15 and 20 years ago. That was the OR1. In fact, I was at this time a consultant from an endoscopic company. I will not give the name. But you see that the OR1 was one of the first in Europe, and had 2 OR1 like that, had 2 operating rooms like that, and I could jump from a room to the other room with the assistant close and finish the surgery of start in the other room. And so we were very active, and finally, more or less, we operate 1,500 cases a year with the team. Well, yes. Most of them, obviously, by endoscopy. I know that at that time, when we had the first OR1, Harry Rich came and made surgery in my department in this room. And also a nice souvenir. A lot of people came also, like Jean-Bernard Dubisson, but Harry came and make a hysterectomy, of course, to make the most. That was a nice souvenir too. We spent 2 or 3 days in Brussels, and we enjoy a lot. You know, Harry, it's always in good. At that time, he was in good health and perfect. He was jumping also with me from a room to the other room. Nice adventure.
That's wonderful. Now this is a picture of you outside the operating room, and there's some famous people here along with you.
When Tamara was born, we made the first World Congress of Fertility Preservation. Victor Gommel was surely one of the gynecologists, was a friend, but when I was very young, he was already head of department in Vancouver. At that time, he was organizing a workshop on microsurgery. And microsurgery was organized by Victor Gommel in Canada and Bob Winston here in Europe. And after that, I had good meeting and a good collaboration at the International Society for Gynaecological Andrology with Victor Gommel. He became a friend, like Bob Edwards. And Bob Edwards was, of course, invited because I have to recognize that he pushed me to start the program of fertility preservation. He was president of honor of this symposium, and as that was good friends, both are good friends, they were invited in my garden. And Victor, only these 2 people were invited in for dinner. You recognize 4 glasses because there is also the glass of my wife. And they spent an evening telling the story from the army, from the war, all this story with the IVF. And they stay until 3 o'clock in the morning in my house. And we have a lot of fun. And again, it's an excellent souvenir. And that was, I sent this picture because that was also always my pleasure when I still meet Victor Gommel, who have in memory this very nice evening with Bob.
That's wonderful. That's a great story. And this, you guys look so comfortable here drinking your wine. It looks like it's probably the summer. The grass is green. It looks beautiful.
Yes.
Oh, so who's this? This guy looks like a rock star next to you. Look at that hair.
Cameron. Oh, the story with Cameron, and he knows that very well, started a long time ago, in the late 80s. And you have to imagine that in the late 80s, everybody was speaking about peritoneal endometriosis and ovarian endometriosis. But in fact, I guess, and I believe, that at that time start also the increased prevalence of deep endometriose nodule, and probably a relation with epigenetic. We have no time to go into details of the epigenetic and endometriose, but that was the deep nodule. And at that time, we were in conflict, Dr. Netzat and myself, because systematically Cameron defended the bowel resection, of the rectal resection. And I start with the shaving technique, and the first publication was in the early 90s with the shaving technique about a series of 200 cases, which was at that time the huge series. Year after year, there was systematically an old symposium on endometriose. There was a session on deep endometriose, and there was always a debate organized by the president of the Congress, Dr. Netzat, in favor of bowel resection, and Dr. Donnez in favor of shaving. And that was, you can imagine, the argument between the radical surgery versus the non-radical surgery, the risk of recurrence, the risk of complication. And in fact, the debate still exists now. And you look at the paper, Infertility, Sterility, year after year, there is a debate on bowel resection, disc excision, shaving, but this debate is not new. And that was a picture in Turkey. Cameron was there. At that time, he published a paper recognizing that the shaving technique gave less complication and more pregnancy than bowel resection. That was a paper from the family Netzat. And finally, the picture represents that we agree together with the same conclusion.
That's fantastic. That's fantastic. And I just smile when I look at this picture, because I look at that hair, and that's, knowing him now, that was a pretty interesting hairdo on Dr. Najat.
Yeah. But I believe that several years he was with long hair like that.
Yes. Yeah.
Now it's not the case anymore, I guess. Huh?
Not so much. Yeah, it doesn't seem as long. He does have it slicked back, but not as long as this. So we're going to go back a little bit further into your childhood. I think were you born and raised in Belgium?
I'm born in Belgium in 1947. I start my medical school at the age of 17 at the Catholic University of Louvain. At that time, it took 7 years to be a medical doctor. I was then resident in the same university to start the gynecology. And at that time, you have to know that the French-speaking and Dutch-speaking University of Louvain, which is sometimes confusing for you. We have such a small country, and we have two universities of Louvain, but there is the Catholic University of Louvain and the Catholic University of Leuven. 50 years ago, there was only one university, and had the possibility to meet Ivo Brossens, Professor Brossens, who was one of the head of department for reproductive medicine in the Dutch part of the university, and I was in the French part. But we had excellent contact, and we maintained. It's thanks to him, thanks to Professor Brossens, surely, that I start also the research in reproductive surgery. But at the end of my residency at the Catholic University of Louvain, this in 75, yes, in 75, I was called by the head of Department of Surgery. And this head of Department of Surgery, Professor Kesten, told me, Jacques, I'm fed up to be called by gynecologists from the moment that there is a small hole in the bowel of some adhesions. You are gynecologist, but I ask you to stay at the university, but before, to spend 2 years in my department. So that I was gynecologist, and I came back like a small resident in the Department of Surgery. And for 2 years, I spent a part of my life to make bowel resection for cancer, bowel surgery, liver surgery. This is the abdominal surgery for 2 years. And when Professor Kesten told me, you should do that, and then you will be a good gynecologist surgeon. And it's true that when there was a lot of adhesions if I should do a bowel resection in a case of ovarian cancer or whatever, I never call again the abdominal surgeon, because I had finally the double specialization. And when I guess that for the future, it's also important for the young people. You are a reproductive surgeon. I guess that we should be able to continue to teach to a younger resident to make surgery and top level surgery. And of course, there are so many things to do in reproductive medicine, the IVF, the endocrinology, the surgery, that it's impossible for one person to be able to do at the top level everything. So that more and more we should select what we want to do and try to be the top in the section we have chosen.
That's excellent advice. And I think that story for me, Jack, hits home, because when I was just out of my fellowship, it was a very unique situation in that I was by myself for a lot of my surgeries, freshly out of fellowship. And one of the people that I really found and attached myself to was one of the general surgeons who was doing a lot of surgery at the time. He was a trauma surgeon, and I sort of hung on to his coattails and would go into the operating room with him, and I really learned a lot. I think I developed a comfort level, like you said, of doing things that I probably wasn't going to be able to do just as a regular reproductive surgeon. So I think that's great advice. And I also hear what you're saying, that as we start to have more and more things that we do, you do want to have a niche that you can develop and a niche that you can call your own, something that you can be very skilled at, but at the same time, maybe develop along those lines a research niche, as you have, that you can really expand and develop a reputation. So that's wonderful advice for a lot of our younger surgeons. That's incredible. So when you were growing up in Belgium, when you were younger, what were your parents like? Were your parents physicians? Did they push you to become a doctor?
No. I was the only doctor in the family. My father was in the business, the bank business, and my mother was my mother. Stay home, she was responsible of my education, and so she helped me a lot. I started the generation of the doctor. I have my son Olivier. He's also a gynecologist.
Yes.
He continued the research with me. He's in France, but we still collaborate in the clinical trial. We try to collaborate for the redaction of manuscript. I push him to continue to do it, because I guess that keeping in mind always what is the future, maintain your brain at the younger stage. I hope that next year, one of my great daughters will start also the medical college. So that I was the first in the Donnez family, but now maybe other people will succeed to follow me.
Well, I'm very jealous, because none of my 3 children want to go into medicine. I think they saw that their father was working too hard, and they decided they want a little easier life. So you should be very proud of your son and very proud of your granddaughter. That's very, very good.
Yes, but when my son Olivier was 16, he told, I will never do the medicine. You are never home. I don't sleep. I don't know my father. And he's doing exactly the same now.
So he did like what you did. Eventually he liked what you did because he saw that you enjoyed it and that you had a passion for it. So why did you decide to go into medicine? Nobody in your family was a doctor. What made you decide to go down this path?
In fact, when I was adolescent, I met somebody, a young girl, and she had leukemia, and she died from the leukemia after bone marrow transplantation because imagine more than 15, well, nearly 16, 15, more than 50 years ago, a bone marrow transplantation was not easy. A lot of people died, and she had a leukemia, and she died. It was surely one of the events which orientated my life in the medicine. And finally, I started the medicine. I was very, very happy. Gynecologist was not my first choice. I would like to be surgeon, surgery, sure. But you will not believe me, orthopedic surgeon, traumatologist. And during the last year, I was obliged to make a stage in the obstetric department. And I made my first delivery as a student. And I was so impressed by the beginning of the life that I decided immediately, I should become an obstetrician. And I became a gynecologist and obstetrician. And finally, at the age of 35, I abandoned the obstetric because it was impossible to do surgery all the day if delivery at the same time or during the night of cesarean section. Both are not compatible if you have a lot of surgery to do. And thus I decided to stop with obstetric at that time and to devote my life to research and surgery.
That's wonderful. So when you were deciding to become a gynecologist, who did you look up to? Who were your mentors? Your mentors, your teachers. Who were the people that guided you?
As I told you, my main teacher was Professor Choquart. Choquart was the head of department at the Catholic University, and his father was also head of department as great father. And one of them, the inventor of the forceps. He teach me the obstetrics, and finally, because we were a mixed university with the French speaking and the Flemish speaking, we had several teachers. And from that came also a different view, not only one who was responsible to teach me. There was a lot of different prof, and we have a lot of experience people to teach us all obstetrics and the gynecological surgery. And as I told you, at the end of my residency, I spent another 2 years for abdominal surgery. And finally, the result, I guess, was not too bad.
Not too bad. You did good for yourself. Now, do you remember, Jacques, your first laparoscopy?
Yes. I was, in fact, you will not believe me, but I was really, really young resident. It is in the year 72, 73, and I was sent to Amsterdam, to the Vrije Universiteit, to learn Flemish, to learn Dutch, because I was from the French part of Belgium, but I was in Leuven and had to make delivery in Dutch-speaking women. So that at least I should
know some Flemish.
some words. And the prof of obstetric was not very happy, and he told me, Dr. Donnez, I will send you several months to Amsterdam, and when you come back, you will be able to speak to the Dutch-speaking women. Okay, I say yes. And that was the start of the laparoscopy, and we did the first laparoscopy. And the laparoscopy was used in Amsterdam only to coagulate the fallopian tube. And when I came back to Louvain, I said we should do a lot of things with that. And that was really the start of the use of laparoscopy, not only for diagnosis, because we start with diagnosis, laparoscopy, but to start to do something. And when I start to vaporize the small lesions of endometriosis, I was so happy. Lesions of 2 or 3 millimeters. Oh, fantastic. We couldn't imagine that 15 years later, we will remove part of the bowel, big nodule, big cyst, uterus, so that, in fact, I know that the abdominal surgeon will be not happy with that, but the laparoscopic surgery was invented by gynecologists.
Oh, as gynecologists, we know that, and you're absolutely right. I don't think the surgeons appreciate that. That's absolutely correct. And one of the things that I remember, I remember when I was first learning laparoscopy, I was training in a very poor indigent hospital, and our instrumentation wasn't the best. And so we still had some of those old teaching laparoscopes. You probably remember those with the two optics where we were both looking, you and your assistant, your heads were butting each other.
Yeah.
Those were the days. I'm sure you did a lot of
people, but it was, and finally it's with the video laparoscopy that we can teach to the other people, but it was not easy. We were with the assistant the same sides of the table looking, and just for us, one of the big advantage came from the use of the camera. The camera represents really fantastic increase of the technique.
What are some of the key discoveries, the key innovations in laparoscopy that have moved it from what you were doing in 1975 to what you're seeing now in 2021?
I believe that there was really a lot of improvement. Also in the quality of the optic, the definition of the resolution of the picture was incredible. And all the equipment, in fact, from the CO2 laser to the harmonic scalpel to the ultrasound, all these equipment allow you to make finally by endoscopy what we did in the past by laparotomy. And in fact, for me, there are not a specific improvement, but from the moment that we start to do surgery by laparoscopy, a lot of new options came available all together, and we were able to do it easily. And I guess that the technique improved by itself by the use of the gynecologists. We start with the small lesions, and then we were more and more confident, so that most of the endoscopists from my generation, they start with a logical learning curve, step by step, because we ignore when we start what was possible to do it. Imagine the first revolution when Harry Rich defended the first hysterectomy by laparoscopy. That was several years later. Everybody was doing that.
Yes.
But what is important to mention that in my department, more or less 95% of the hysterectomy for benign disease were performed by laparoscopy. But you are still, and I'm sure that is the same in US, there are still some countries, some cities where the rate of laparotomy for hysterectomy is more than 60-70%. And it's also our responsibility, your responsibility, John, still my responsibility, to teach young people to do it and there are still too many laparotomy for benign disease, and it's a battle, and continuous battle, to force the people to change their mind.
No, you're absolutely right. And I think there are areas in Massachusetts where in Boston, most things are done laparoscopically, which is great. But if you go to the other part of the state, more things are done through laparotomy. So even in a state like Massachusetts that we think is very modern and sophisticated, we still see these discrepancies. So you're absolutely right.